what patients really like is we can initially examine that pelvic floor externally. And how we do that is we use ultrasound imaging. So with ultrasound imaging, so it's a bit like the imaging that's used during pregnancy. So you put that ultrasound probe, lower abdomen, kind of just above the pubic symphysis. So if I had that, which I should have brought, you'll have to admonish me for not bringing it, but maybe the next time I'll bring it. So if you put an ultrasound probe on here, that gives you on the screen big picture of the bladder, and when you do a pelvic floor contraction, the base of that bladder will elevate. So on the screen you can see the bladder. If Jack were to do a big pelvic floor contraction, the base of the bladder would lift up. So that confirms to me he's getting a contraction. It should relax, contract, relax. If it's overactive, you get less movement in it. So you get less movement or no movement. So that's a way that I or one of my colleagues can initially assess Jack's pelvic floor externally. So I think one thing that's helped bring people from the musculoskeletal world into pelvic health is initially they can use that ultrasound imaging to assess that pelvic floor externally. And patients like that, I think, that they can see what's happening internally by just doing that transabdominal scanning.
Sorry to interrupt you there, but are you saying that for your work, ultrasound scanning is an essential tool, or can it be done without? Because my own experience is that it's a great tool. They're within the budget of many clinics now, but you've still got a lot of work to be able to interpret what you're seeing on your screen.
Yeah, I don't think it's essential, but it's really useful.
Okay.
Transabdominal scanning is relatively straightforward to do, because all we're doing it is as part really of biofeedback. So we're not looking at, is there a bladder pathology? We're not looking at the bladder neck. We are looking at, can this patient easily contract and relax that pelvic floor? So that the level of skill for transabdominal scanning is relatively low, and it's definitely not diagnostic scanning.
Okay.
What we would get Jack to do with the ultrasound is, so if you just bend the knees up, and you can do this at home. You can do this at home or wherever you're watching. So the pelvic floor has got fast fibers, so fast twitch fibers, and slow twitch fibers. So with a patient who's got pelvic pain or athletic pelvic pain, we want to see, can they contract both types of fibers? So we want to really work out, can they do that posteriorly? So that's around the back passage or rectum. And can they do it front? So in males, that's around that kind of urethral sphincter, that bulbo muscle. So you're at home. What you're going to do first of all is some fast twitch rectal contraction. So this is where you're going to squeeze around the back passage, really strong and quick, let go. So you're going to do 10 of these. You're going to squeeze, let go, squeeze, let go. So you're going to do 10 of those. So we'd get Jack to do 10 of those, and I would look and see what's happening on the screen. But I also want to know what's happening with Jack. Now, most of you at home, when you do that contraction, it shouldn't be painful. With the pelvic pain patients, it can be painful, or they can say, well, actually, that's giving me that feeling of scrotal discomfort, or that's giving me that feeling of the golf ball in the rectum. So we're seeing really when they do that fast twitch rectal contraction, is it painful? And it shouldn't be. When you're doing it at home, you should probably be able to do a contraction and let go, and then contract and let go. What you find with the pelvic pain patients is after they've done a couple, it's much harder to relax the muscle. So what they tend to describe is, well, I'm not really sure what I'm doing now. I'm trying to relax it, but I kind of feel I can't. So they're kind of stuck in a bit of no man's land. And what you tend to see on screen is you get this lack of movement. We also want to see what's happening when they do that endurance activity. So what I'm going to get you to do this time is, let's still squeeze around the back passage, but you're going to do a lighter contraction. And you're going to hold for maybe 10 seconds. So lighter squeeze and hold for 10 seconds. And let go. And then just squeeze again and let go. Now, similarly with Jack, those of you at home, that shouldn't be painful. Some of you might find it easy to do. Some of you might find it difficult. But it shouldn't be painful. But with these patients, it can be painful. It can cause discomfort. Or it can give them a feeling of it going into spasm or a lack of endurance where they can't maintain that contraction. So that indicates that there is some degree of dysfunction there.